All right, welcome everyone. Might get started just because it's past 2 o'clock. And for those joining at home, thanks for taking the time to join. And firstly, congratulations for making it through the acting CM program. And today I'm just going to do a brief little talk to you about vasopressor and inotropes in the Resus bay. You're working in Resus, and you're all confident with vasoactive infusions, but it's time to actually go over a bit more in depth around some of the nuances around these drugs, because as you step up into the R2 roles, you need to have a bit more of an understanding around them. So I thought we'll just touch a bit on shock and go back over that. Then we'll look at some of the evidence for vasopressors and inotropes. We're going to talk about which drug and when, and I'm going to go over some case studies, and feel free to ask me questions as we go along. So when we look at shock, generally it's broken up into 4 main types, where we've got your distributive type shocks, which is your sepsis, your anaphylaxis, neurogenic. And these patients classically present where they got leaky vessels, they got decreased systemic vascular resistance, they're vasodilated, and from that vasodilation, they get this melded distribution of flow throughout them that gives them adequate tissue perfusion. Cardiogenic, we often miss this. We do see it quite a bit, and it's kind of synergistic with lots of different types of shock. But the examples where we see it classically can be in acute myocardial infarctions, myocarditis, certain arrhythmias, so ventricular storm, even some of your rapid AFs can present cardiogenic shock. Well, something also that we miss is when the valves start to fail. So when you get tricuspid and mitral regurgitation acutely, that can present in cardiogenic shock. And so basically you've got this pump failure there. Hypovolemic, generally it's because they're bleeding, and we see it a lot at Charlie's with our GI bleeds. But you can also see it in hemorrhage from trauma. DKA will also present hypovolemic because they got that relatively poor perfusion from being so depleted due to hypovolemia. Obstructive shocks, these present classically quite suddenly and quite unwell. If we don't do something quickly with the obstructive type shock pitchers, they get sicker quickly and they go down this spiral. Okay, and so they get this impaired filling and outflow tract obstruction, okay, where the heart's not able to pump out against that obstruction that's there. So PEs, tension pneumothorax, cardiac tamponade, the big ones. Aortic dissection is a bit of a mix of obstructive with cardiogenic type shock, and if it ruptures, it can be hypovolemic shock as well. But basically all this results in this tissue hyperperfusion, where they get hypoxic tissues, metabolic acidosis, leads to worsening organ dysfunction. And when they start knocking off organs, once one goes, then multi-organs will start to fail, because they all need that good homeostasis that we learned early on in pathophysiology. I'm a bit of a simple soul, so I look at it as more as a pump problem. So if they've got poor contractility, the tank problem, where they've got insufficient effective circulating volume. Is it a pipe volume problem where the pipes have got leaky and they're not stiff and toned and giving an adequate systemic vascular resistance? We often think about it as pulse could be a problem as well. So severe bradycardia or severe tachycardias can result in shock as well from that. And this is kind of the spectrum of shock that we see these patients in. So quite often we can see a cool shock, where these patients look quite well initially, but they've got early signs of shock developing. So they get this hearing hyperperfusion. We'll talk about how you recognize that. Okay, because they often have normal blood pressure and normal heart rate. We'll see compensated shock patterns where they often will elevate a tachycardic response. They'll try and clamp down and vasoconstrict to maintain BP, but they're still actually hyperperfusing the tissues and they're kind of on this knife edge. And then we get the other patients where they stop decompensating, okay? And so this is when they present decompensated shock. And so we'll see hypertension, they're unable to maintain good perfusion, their brain starts going off, you get cardiac failure, respiratory failure, renal failure, hepatic failure, and coagulopathy. And they're in this circle, and that's what actually kills them if we don't intervene and try and correct things there. When we look at it from what the body's actually trying to do, so you've got your sympathetic system that will always try and compensate for shock. Okay, so it'll try and clamp down the vessels, give more preload, generate more pressure and stuff. And so there's two forms of that can we see. So quite often we'll recognize the sympatho-excitatory stage. So this is where the cardiac output starts to drop. They're going to increase their heart rate. They're going to increase their systemic vascular resistance to try and maintain a normal blood pressure and normal perfusion. And then when they start to fail that, that's when we start seeing that they lose cardiac output. Their heart rate starts going down. Okay, that's when bradycardia, so that's a pre-terminal sign in the shock patient. Systemic vascular resistance causes this profound vasodilation. They get this profound hypertension and stuff that comes along with it. So we need to recognize these patients early when they're in that sympatho-excitatory stage, and not when they're in that inhibitory stage where they've lost that ability to compensate anymore. And so we kind of get a bit fixated on blood pressure, but blood pressure doesn't always equal perfusion. And this is what we sometimes go down the rabbit hole a bit with these patients now when we get fixated on the blood pressure. And sometimes the blood pressure is okay, or it's relatively normal, or it could be a bit lower than what the patient's normally hypertensive is. But what we actually need to focus on a lot more when we're assessing shock is actual tissue perfusion, and not always get fixated on the blood pressure, because patients can be severely shocked and still have a normal blood pressure. So when you're at the bedside and you're trying to recognize these patients, don't ask yourself, is my patient hypertensive? You want to actually think a bit above that, and you want to ask yourself, is your patient actually hyperperfusing? Okay, and the way that we actually do this is at the bedside. The things that we want to look for is we want to look to see their mental state and their work of breathing. Okay, so that tells us what their brain, their respiratory system's doing. We want to look at their skin color and their mottling or diaphoresis. And we want to look for obvious bleeding or fluid loss. We want to touch these patients, okay? Because what their peripheries are doing tells us how well they're actually perfusing their tissues. They can have a blood pressure of 120/88. They've got cold, shut down, mottled extremities, and they're shocked. Look at our macro circulation and be falsely reassured by having heart rates, blood pressures, mean arterial pressures and that. But we know that SATs and the perfusion index that come off that SATs actually give us a bit more information about how well they're perfusing. More numbers that take a little bit while, okay, in the initial stage, so urine output and lactate trend, but over a period of time, to have these patients sitting in resus for a couple of hours and that, actually look and see what they're doing. And the last thing we can do is we can put an actual probe on the chest and we can look at what the lungs doing, we look at what the heart's doing, we can look at what the IVC is doing, and that information that we get from doing the ultrasound can actually tell us a lot. So the thing to actually look at from these patients is, well, often nurses, we get fascinated by this macro circulation. So we want to know what the blood pressure, heart rate, urine output, cardiac output and stuff is. If you actually look at when the intensivists come down to assess our patient in resus, the first thing they do is they always assess the microcirculation, okay? Because this tells us how well the patient's perfusing. So you see them, they'll lift the covers off and they'll touch their hands, they'll touch their feet. They'll do a capillary refill time. They'll look for mottling around the knees. They'll feel the skin temperature and they'll look at the lactate in that. All that information is telling us what the tissues are actually getting from what those macrocirculatory numbers are actually doing. So don't be afraid to touch your patients and go to the bedside and not just rely on all the information they're actually getting from the monitor, all right? There's a lot more at the bedside that can tell us how well patients are perfusing and where they are in that stage of shock. If we notice things like raised capillary refill time, mottling, or skin temperature and that, then we should guide our resuscitation to try and correct that. And one thing I've learned earlier is that shock is the next door neighbour to death. So any patient's got any signs of shock, we want to be aggressive with our resuscitation. We want to do everything to try and stabilise them, to actually try and beat that spiral. And the earlier you can recognise shock, better chance these patients have of surviving. So then what's our approach at the bedside for these patients? Okay, I've put this in the readings for this week and that. So this is the guide called the minutes bundle and stuff. So when you get a sick patient put in front of you that's got signs of shock, first thing we want to always do is assess the ABCs and assess that. We want to then look for those obstructive causes early. So things like pneumothorax, cardiac tamponade and stuff. We can do something quickly because you're not going to be able to resuscitate these patients unless you reverse that obstruction that goes on. If they're bleeding from somewhere, you want to compress it. It can be tourniquets, it can be pressure, it can be start blood resuscitation. Then we want to start our infusions and investigate further. So this is where we might go for early fluid resuscitation, early blood resuscitation, early vasopressors or inotropes, or all three at the same time, depending on what type of shock you actually deal with. I want to start our investigation, get a blood gas off, see what the calcium is, seeing what the lactate is, seeing what the pH is. We're really lucky where we work is a lot of our medical staff are very competent with ultrasound, and that can really rule out those obstructive causes very early. While we're needing CT scans and chest x-rays and that, just having a probe at the bedside can tell us what the heart's doing. They can tell us what the IVC is doing as well. Well, there we want to start treatment of the underlying etiology. So if they look like sepsis, we want to get antibiotics in early. If they start bleeding, we want to think about things like tranexamic acid, anticoagulation reversal, fluid resuscitation with blood products. We want to try and stabilize these patients early and aggressively. Okay, so think of it on this minute structure as you're actually approaching these patients. And now I'm going to just focus on vasopressor and inotropes. So these are the conditions and the patients that you're going to actually start vasopressors on. And so we know that vasopressors, they actually target the blood vessels. So it's going to actually clamp down those blood vessels. It's going to increase your systemic vascular resistance, and it's what our mean arterial pressure comes from. Okay, so once we start using vasopressors, we want to titrate it to the mean arterial pressure. And we know that with shock states, most shocks just need a mean arterial pressure of above 65 for good organ perfusions. That's cases where we want to drive for a bit higher mean arterial pressure. So a MAP above 80 are going to be things like spinal cord injury, head injury, and that where we want a bit of that. So that's cerebral perfusion pressure and stuff. Inotropes is if we've got pump failure or the heart's not. And so we need to increase our cardiac output to actually increase the heart's ability to contract. That's going to deliver oxygen to the tissues as well. Okay, but remember, if you haven't got a good mean arterial pressure and you start using inotropes early in these patients, you're going to make the patient sicker because you need to have good tissue perfusion. So that MAP above 65. And if you just start squeezing the heart and that, then it's not actually going to perfuse the tissues till you've got your MAP above 65. So the first point to take away is always aim for a MAP of 65. So use your pressures for that, and then look at using inotropes if you need to, depending what you're dealing with. And all these drugs target these certain receptors within the body, okay? And so there's different receptors for different drugs, okay? So we use a lot of alpha receptor antagonists, with the big one being noradrenaline. Noradrenaline is great because it has a little bit of beta, so it can help with the heart's contractility or beta-1 stimulation and that. But alpha-1 is where we're going to target that smooth muscle, so it's about tightening up the vessels. Beta-1 is in the heart, so this is where where a lot of our inotropes work on. So this increases the cardiac contractility and the heart rate. Beta-2 receptors are a bit more vasodilatory. There's a group of drugs called inodilators that actually help with the heart's ability to pump, but it also relaxes it a little bit. We don't use these much in ED, so I'm not going to target these or talk about them today. Dopamine receptors and that, we know that they're in the renal, the mesenteric, coronary, and CNS and that. And stimulating these can work as a vasopressor type agent. That's where dopamine and dobutamine to some extent targets these dopamine receptors. But we've moved a lot away from dopamine because it has a bit of a nastier side effect profile because it does cause a lot of adverse tachycardia from it. And then the last receptor, what we look at, is in the vasopressin receptors or the B1 receptor. And this is where vasopressin targets. Okay, so these start up in your brain. Okay, and so you've also got these receptors in your kidneys and your adrenals. And stimulating these vasopressin receptors are actually pure vasoconstriction, is what comes from it. So this is another form of vasopressor. But we tend to target these receptors after we've hit the alpha, the beta-1 receptors, and then we'll look at targeting the vasopressin receptor from there. And so this is just the different drugs broken up into their three classes. So you have your pure vasoconstrictor agents. So phenylephrine, we don't use that much down in ED. They use it a little bit in theatre for certain cardiac surgeries and stuff, and maybe a slight bit in ICU. Vasopressin we use as a second line agent during our septic shocks or our distributive shock patients. Angiotensin 2 is a new drug on the market. It's very hard to get in Australia at the moment, but there are a few ICUs using this, and because it is a potent vasoconstrictor. We then look at our drugs that provide us with this inotropy and vasoconstriction, and the best one being noradrenaline. So we use quite a lot. ICU use this a lot in theatre. Adrenaline works really well as a vasoconstrictor, but it also has a little bit more inotropic and stuff. So adrenaline actually works quite well with noradrenaline. So if you've got a patient that's in septic shock and they're getting a bit of cardiogenic shock and that, adding in a bit of adrenaline can actually improve their contractility and heart rate. And so quite often run adrenaline as a third line type agent behind noradrenaline and vasopressin to actually help with the heart's ability to contract. Dopamine, it's kind of gone out of favor in that because it has this poor side effect profile. Okay, and we know that noradrenaline is a lot more better in that. The drugs that are more inotropes, but they also can do a bit of vasodilation. So these are the ones that we may use for cardiogenic shock. So the main one we're going to go for, if adrenaline's not helping us in ED, will be dobutamine, because it's going to increase your contractility, your cardiac output, but it will lower your systemic vascular resistance. So if you haven't got a good map and you just start them on dobutamine, you're going to make them sicker. You've got to get your map up. So that's where you might use noradrenaline first, get the map up, and then add dobutamine in. Your PDE3 inhibitors, so milrinone, okay, is something that they might use a bit on CCU. Same with your calcium sensitizers like levosimendan. We're generally not going to reach to them in ED, and they're more for the extended cardiogenic shock that they're actually managing up in CCU from that. So I guess when we're going to start these agents, we need to ask ourselves a few questions. And the first one is, what is your patient's underlying shock physiology? Or what are you hoping to achieve? So do you just want systemic vasoconstriction? So you want to tighten up the systemic vascular resistance to actually generate that good perfusion pressure? Do you want some systemic vasodilation? Do you want to increase the inotropic, so where they've got low cardiac output? Or do you want some pulmonary vasodilation? And then you've got to ask yourself, how can I modify that physiology to actually improve tissue perfusion? If you want to increase the systemic vasoconstriction, then you're going to increase the SVR, which will increase your MAP. You want some systemic vasodilation where they've got congestion, but they're still shocked. You're going to increase your MAP with some inodilating agents as well that will drop your systemic vascular resistance. Just want to increase their cardiac output, then you're going to go for an inotropic. And sometimes we want to do some pulmonary vasodilation as well, especially if they're getting congestion. And that's where we're going to lower our pulmonary pressures. But all these drugs have side effects, okay? Every single one of them. So you need to ask yourself, can this patient tolerate some tachydysrhythmias? And if they can't, we're mostly not going to reach for dobutamine, okay? Can we make them more vasoplegic, can cause worsening hypertension? Then we're not going to go for drugs like dobutamine if they're MAPs in their boots. These drugs will increase their pulmonary pressures, which can cause right ventricular strain and also hypoxemia. We also know that they're going to shunt blood away from the peripherals and from the gut, so you can get mesenteric vasoconstriction and hyperperfusion. And quite often you need a combination of 2-3 of these drugs to actually make a difference. And we'll talk a little bit about that now. The case number one. So this is a 24-year-old male. He's playing rugby and he comes in with this severely displaced ankle fracture. He gets given 200 micrograms of fentanyl and 150 milligrams of propofol to actually pull the ankle. Next minute, his blood pressure is 76 on 38. This is when we're going to reach our push dose pressures, all right? So this is where we're going to aim to temporize blood pressure. Quite often we use these as a bridge to infusion. And the two main options that we have down in ED that we'll go for, that everyone's kind of familiar with, is metaraminol. So that's where we'll give 1 to 2 milligram bolus, or we'll go for adrenaline, so 10 to 50 microgram bolus, and that. And they both will. And they're short acting, they're very temporary. And they're great for when we're doing these procedure sedations. We give a little bit too much propofol and the blood pressure drops. And so these are what we call push dose pressors for that. Moving on to case number 2. So this is a 43-year-old male. He has a long-term IDC, he comes in, and he comes in with urosepsis, and that's what it is bad. You can see it's cloudy, lots of sediment there. His blood pressure is 86 on 54. He's tachy at 135, and he's had 3 litres of saline. What are you guys going to do next for this patient? Call out some answers to him. What are you going to give him? No one wants to answer.
He's probably going to need some noradrenaline.
Yeah, perfect. Who's going to give him metaraminol? Anyone? That's good, because we want to avoid giving metaraminol to these patients. This patient's clearly had 3 litres of fluids. His blood pressure's still in his boots. He's still tachycardic and he's still got signs of shock. All right, and using push dose pressures for these patients. Okay, all you end up with is this, it's like putting them on a roller coaster with their blood pressure and their perfusion. You're not actually getting sustained perfusion. All you're doing is making the numbers look good briefly and making us feel better, but it's not actually doing anything for the patient and that. So push dose pressures are great for when you've got a bit of procedure sedation, or you're doing an RSI and you're just optimizing the actual blood pressure during those periods where you're putting them on positive pressure and giving them a big slug of propofol. It's great. The patients that are shocked and have got times of tissue hyperfusion, we need to just start them on an infusion. And Connie, you're 100% right. Noradrenaline is not always the best answer, but it's rarely the wrong answer. And so it should be the one that we reach for first in these patients when we need to actually start an infusion. The noradrenaline, the reason we like it is that it has alpha and beta, so it's very much will clamp down on those leaky blood vessels and tighten them up. It also has slight beta agonist effects, so it's going to help with the heart's ability to contract. So this is what we call a vasopressor with mild inotropy. Remember, in obese patients, we're going to do this in our ideal body weight. And when we're titrating it, we're going to titrate to the mean arterial pressure, because that's what tells us at the bedside that we're actually winning with our systemic vascular resistance. And what we go for there is 60 to 65 is what we're looking for organ perfusion. Thing with noradrenaline and that, there is no maximum dose of noradrenaline. Okay, you can keep going up. But once you get to about 30 micrograms a minute, that's when we want to start adding in a second pressor, okay, to these patients, okay, because your effects from the noradrenaline is going to start running out and not be as effective in actually maintaining perfusion for these patients. It is safe peripherally, but in saying that, are we going to run a noradrenaline infusion through that cannula there? I'd hope you'd all say no, all right? So we want to make sure we've got a big line in, generally in the mid-forearm, avoiding the ACF, at least size 18 or above, okay? So it is safe to run peripherally. There's multiple studies in the adults and pediatrics that show this, but you want to make sure that it's actually into a decent vein, into a decent area that's not going to risk extravasation. Once we hit that 30 mics per minute, that's when we want to chuck in a second agent. Okay, and this is when we'll go for vasopressin. We target that V1 receptor. Okay, so vasopressin works, the potent vasoconstrictor, and it works to reduce the noradrenaline requirements. Because it targets that V receptor and that, it works quite well in metabolic acidosis, where we know that the alpha and beta receptors are going to struggle in that. And so we like it in patients that also those that have quite a lot of fried adrenals, so those that are on chronic steroid use. I'm talking about corticosteroid steroids, and for those that use meth, because we know meth stimulates your adrenals quite a lot. The thing we know with vasopressin is you don't titrate it up, okay? So we started generally as an infusion. We generally will max out at 0.0 units, 0.06 units per minute. Okay, there is some ICU cases where they've gone up to 1.2 units a minute, but generally we start at 0.4 to 0.6 units per minute, and we just leave it as a background infusion. The higher you go up in this, the risk of mesenteric ischemia, digital ischemia can go ahead. But you also, depending on what shock state you're dealing with and how sick they are, you may have to go higher. Once we're chucking in vasopressin, that's when we generally need to chuck in a second line, a central line at the same time, okay? You can start vasopressin peripherally, but you want to be bridging to a central access within the hour to actually get these patients onto central infusions, because they are going to get digital ischemia from them if you run high doses of them peripherally. Once you're starting a second pressor, that's when we want to stimulate the adrenals, and that's when we're going to give them bolus doses of hydrocortisone. Other indications where we may consider giving hydrocortisone is severe community-acquired pneumonia. There's 2 studies published in 2024 that showed there was some benefit in that. Okay, for those that are getting admitted. You're on chronic steroid use for like the rheumatoid arthritis and stuff, then we're going to give them steroids, or if they've got Addisonian crisis as well. Remember, when we're dealing with septic shock and that, up to about 40% of patients with septic shock will get sepsis-induced cardiogenic dysfunction. They're getting impaired myocardial circulation. They're getting direct myocardial impression from the infection, and they get mitochondrial dysfunction, all right? It is underappreciated, but it is acute and reversible. So this is where we may add in a low-dose adrenaline infusion, or we may put them on an inotropic agent like dobutamine or milrinone for that. If you're starting to go up on your vasopressor agent, so you know adrenaline, you've added in vasopressin and that, the heart's going to start struggling, and this is when we may run a low-dose adrenaline infusion, the background to these patients as well. Moving on to case number 3. This is the case I had a couple of years ago. It's an 18-year-old male. He's ingested some amyl nitrate. And so amyl nitrate is a potent vasodilator. It's used a lot in the homosexuals because it relaxes everything, can give them more pleasure and that. So we do see it from time to time. Okay, but it can result in methemoglobinemia, which is what we were worried this kid had when he came in. He presented shocked. His blood pressure was 65/45. His heart rate was 160. He had no rash or anything over him, so we were still quite worried. So we inserted 2 IVs. We did the quick gas, and it came back as a normal methemoglobin level, so that ruled out methemoglobinemia. We gave him 2 litres of saline very quickly over about 5 minutes, and his blood pressure was still 70 systolic. He was complaining of this tightness in his throat, but he had no rash. Okay, so we thought, could this be anaphylaxis? Okay, and so we gave him 0.5 of adrenaline, IM, and all these symptoms resolved. Blood pressure improved, everything improved in that. And so he got better quite quickly. And so it was an allergic reaction actually to the amyl nitrate that stimulated a big histamine release that's caused it. Remembering if you're dealing with shock and it's not responding, or you've got a shock patient, you give them antibiotics and stuff and they get sicker, always think about anaphylaxis in these patients, okay? Because 20% of the time with anaphylaxis, they won't actually have a rash. They'll just vasodilate, Okay, we see this a bit in kids, all right? We often can think it's asthma, but they've got tight throat and wheezing, so give them lots of salbutamol on that. And actually, they just need a decent dose of adrenaline in them. Remember, patients that are vasodilated, not giving them IM adrenaline. Generally, if the ambos have brought them in and they've had 2-3 doses of IM adrenaline, they're so vasodilated, it's not actually getting into the systemic circulation. They just need to be given IV adrenaline infusion, and that'll turn them around quite quickly. So always think about that, okay? And so when do I use adrenaline? So if it starts with A, we should think about adrenaline first. So cardiac arrest, asthma, we like adrenaline because it's got beta 2 and beta 1, so bronchodilator, anaphylaxis, angioedema, and your AV blocks with your heart early on, putting them on adrenaline infusion. And so if it doesn't start with A and it's not one of those 5 conditions, then I'm going to go for noradrenaline first. But just remember that, okay? They're the 5 things where we'll go with adrenaline first, whether that's IM, IV, bolus, or infusion. Look at that for it. Adrenaline infusion, we've made it really simple. There's now a peripheral dose as well. It's in the Resus guidelines. Go have a read of it. We are using adrenaline infusions in cardiac arrest a bit more, and it's going to be very much consultant dependent. And so if you're in with some of the consultants, it's mainly going to be the ultrasound guides. They're going to want to get an outline in early into cardiac arrest. And because we know that when you give boluses, that 1 milligram of adrenaline, you just get these peaks and troughs that comes up, and you actually lose coronary perfusion pressure. And we want to actually maintain coronary perfusion pressure. That's the whole reason by doing the CPR on the patients, is to generate that coronary perfusion pressure. If we're actually titrating adrenaline infusion, we can actually maintain that coronary perfusion pressure, which will actually help give us cerebral perfusion. We know that coronary perfusion sits between a diastolic blood pressure of between 30 to 40. So putting an outline in and actually titrating an adrenaline infusion to that diastolic pressure between 30 to 40 can actually try and help maintain that cerebral perfusion pressure. And then we can work on trying to get return of spontaneous circulation in these patients. So if you're ever in a code with some of the consultants, some of them are actually going to this now. And it's actually been done a lot in the UK and certainly in America at the moment as well. There's not amazing evidence, but there's not amazing evidence for anything that we do in cardiac arrest at the moment either. So it is something that we're trying, and hopefully we can have some good outcomes with it occasionally. Moving on now to case number 4. This is a 28-year-old male, comes in, got cool peripheries, capillary refill time of 5 seconds, got an ultra-mental state, got these deep cosmal respirations. We look at his gas there and his vital signs. It's tachy at 135, blood pressure is 82 and 44, respiratory rate 34, and temps 39.1. Sugar's up, his ketones are up, pH is down at 6.88, bicarbs in his boots, and his lactate. He's got this DKA, he's got an infection, he's also severely acidotic. Bit of a nightmare patient to try and resuscitate and manage. Okay, so when you're dealing with DKA, he's going to get profound volume depletion from the osmotic diuresis. There's also febrile and tachy and stuff with the high lactate, so you've got vasoplegia, capillary leak from an underlying infection. There's also severely acidotic. That's going to cause myocardial and vascular dysfunction. And from it, get catecholamine resistance from it. And so what it is, so you get this patient in, you've given him 2 liters of fluid, you started him on an insulin infusion, blood pressure's still in his boots. You started noradrenaline, started 0.5, gone up to 1.5, gone up to 0.3, gone up to 0.5. And you're just ramping up the noradrenaline, but his BP's coming down into his boots. His BP's 78 on 40, capillary refill time's going up, diffusion index 0.3, lactate's rising. So why isn't the noradrenaline actually working in this patient? And so noradrenaline likes to sit and works its best with a pH above 7.2. Once you start going below 7 and that, this is where you get into this acidemic trap. So the pH will drop, you get worsening contractility of the heart, so the pump weakens, Catecholamines then get poorly responsive to it, and pressors lose their effect, especially noradrenaline and adrenaline. Vasopressin, not as much. They get this worsening hyperperfusion from it. And so from that, then the lactate goes up and the acidosis worsens from that. And so your noradrenaline is not going to work with someone that's so severely acidotic. Okay, so this is when we might give them some bicarb therapy. They're intubated, we might hyperventilate them a bit and give them more fluid resuscitation. We're going to try and correct everything. The bicarb can sometimes give this temporary correction of their pH, okay, to actually make your noradrenaline work a bit more effective. So we may start push dose bicarb where we're giving 50 to 100 millimoles, and we'll just titrate small IV bolus, and we'll assess the pH, we'll assess the hemodynamics from it. Other thing we can do is we can run a bicarbonate infusion. So this is where we give them 850 mils of water for injection with 150 mils of bicarb. Okay, and so this when we run it at 250 to 500 mils an hour. So you're giving them that. We notice then once they start actually correcting the pH and stuff, then the noradrenaline is going to be a lot more effective. But you can get in this spiral where you keep ramping up the noradrenaline as the pH is going down and further, and the patient will then rest in front of you. And so you need to think about it. The noradrenaline is not working. What is the pH doing, and is it getting worse? And do we need to resuscitate them a bit more aggressively? So we gave this patient a bolus of bicarbonate, and you can see their pH goes up to 7.05. Still acidotic and still sick as a dog. The blood pressure is going to increase. Perfusion index goes up, capillary refill time drops down, and the noradrenaline requirements actually decrease to what they actually need. Okay, so use it as an adjunct. Okay, it's not going to correct the patient, turn them around, and they'll be admitted to LOBS, but it's going to make them a bit better, and it's going to decrease your noradrenaline requirements in these patients. So let's finish off, and we'll go back to our urosepsis case. So we've got our noradrenaline up to 80 mics per minute. Vasopressin's maxed out at 0.06 units a minute. We've given 200 of hydrocort. His blood pressure's down the exposure to 66 on 41. So this patient's circling the drain in front of you. And generally, if you've got escalating vasopressor doses in sepsis, you haven't got good source control. So if you're maxing out and you're going up on your adrenaline, your noradrenaline, your vasopressin and that, and you're dealing with sepsis and that, it isn't a distributive shock or a vasoplegia problem, it's generally a pus problem. And so you can give them all the drugs in the world and that, but until you actually get source control on those patients, they're just going to get sicker. And everyone's fascinated in ED about time to antibiotics, but no one ever looks at our time to source control and getting these patients to theatre, and that's what actually makes a difference. So draining the abscesses, the collections, the empyemas or the ascites, removing those infected lines, devices or foreign bodies, debriding that necrotic tissue, infected wounds, and controlling perforation, leak and obstruction, and that is what will actually make a difference for these patients. And so this patient is what we call refractory shock. This is a lethal manifestation of cardiovascular failure, defined by inadequately hemodynamic response to high doses of vasopressin medications. All right, and so they get in this spiral where they're shocked, you get tissue hyperperfusion, the heart goes, and once you actually start getting this release of vasodilators, which is the main one we see is nitric oxide, which is a potent vasodilation, and this can added in with the systemic vasodilation, this is when they get really vasoplegic. Okay, we need to start reaching for some really hard-hitting vasopressor type agents that are actually going to try and decrease all that nitric oxide production that's going on. And so our three therapies that we may go for. So angiotensin 2 is a new drug on the market. It's been used in a few ICUs over east at the moment, and I'm sure it'll come over to Western Australia soon enough. And there's a lot of trials coming out of America. And so it's this potent vasoconstrictor of the AT1 receptor, so angiotensin receptor, that will increase your SVR and your MAP. Drugs that we have available to us in ED that we may go for is methylene blue, okay, like reduced hemoglobinemia. This will also inhibit nitric oxide, Okay, so our dose is going to be 2 milligrams over 20 to 30 minutes, and then we're going to run it in an infusion over it. Have to be careful that methylene blue can cause serotonin syndrome. So those that are on SSRIs, SNRIs, or have a G6P deficiency can actually get serotonin. So if you've got vasoplegic shock, you give them serotonin syndrome, they're not going to survive that. So you just need to check for those agents before you give them methylene blue. The last one we can use is hydroxycobalamin, okay, which is used as what we use to treat cyanide poisoning. So the cyanide kit, basically it's vitamin B12, but it's 500 times the dose. So it's 5 grams of vitamin B12. And you give it as an infusion over 15 minutes. And it's used for a refractory vasoplegic shock, particularly in sepsis. And they use it a bit in cardiac surgery upstairs to actually get these patients off cardiopulmonary bypass from that. It just tightens everything up. So the last couple of things I'll leave you with is just some pressor perils and pitfalls, right? So when you're drawing up pressors, all right, always try and go for 5% glucose because pressors are more stable in glucose than that. You're better off using multiple agents at lower dose, that adding in rather than flogging one pressor at a higher dose. And saying that there is no maximal dose, but know that when you are actually running out of benefit, and then when you should add in a second and a third pressor. When you're titrating these effusions, it's best to titrate them aggressively to start with, okay? Because when we go for small volumes, especially when we're using the central doses, it can take a while to get into the system. So it's best to overshoot. You often have art lines in these patients, and then you can start titrating it back. And echo can really help us to actually know what effect it's doing on the heart and the vessels to actually guide and titrate it from there. These drugs do come with complications. So ischemia can occur, okay? And so we can see mesenteric ischemia. We can see tissue ischemia to the digits and the limbs and that. So there are risk of tissue ischemia and necrosis to the toes, to the gut, the kidneys and that. So you want to assess all of these. And this is where your ongoing assessment of that microcirculation will actually pick up if you're actually worsening with that. Pressor endpoints, or how do you know you're actually winning with your pressors, is that you want to look for improvements in your microcirculation, getting warm, perfusion index is coming up, capillary refill times coming down, mental status is improving, kidneys urine output's improving, capillary refill times decreasing, lactate's decreasing, that's improving. And the last thing I'll leave you with today is remember alpaca. So if you've got a patient on infusions and they're not improving, or they suddenly get worse than that, remember the alpaca. So if the blood pressure suddenly decreases or gets worse, check your transducers, check your limb leads and stuff to make sure that it's all effective. Check a manual blood pressure. They suddenly start getting sicker and that, check your lines to make sure that the vasopressors are actually going into a vein and that they haven't actually tissued. Get your POCUS out, so get the ultrasound consultant at the bedside, check what the heart's doing, rule out any obstructive causes. Consider adrenal insufficiency and giving them hydrocortisone. We know that pressors work better with a calcium, an ionized calcium above 1.1. So always titrate your calcium and give them boluses of calcium gluconate to get above 1.1. And if they suddenly deteriorate and think, could this be anaphylaxis? And if they're already shocked and vasoplegic and that, they may not present classically with the rash. So think about anaphylaxis in these patients. So that's all I've got time for you today. So if there's any questions, I'm happy to take them. And I'll stop the recording.
Thanks, Kane.